breakdown is very simple to remember. So the breakdown is SSRI, SNRI, TCA, MAOI, and atypical antidepressants. So this is the five classifications. So under SSRI, which we call selective serotonin reuptake inhibitor. So we have more than three, but I just focus on the three that is commonly used. We used to have a Plasil here, but because Paxil has a lot of what we call erectile dysfunction and other anticholinergic effects, so it's not usually used now. So, but always remember, at least I always say to remember these three because most of these three is mostly safe than the Paxil. Paxil is the one with lower half life. Okay, but these three, especially for example, sertraline is safe for somebody that have cancer. Prozac is safe for younger people. Estalopram is safe for older people. So these three, is usually safer than that one. But you need to remember the mechanism of action and the key consideration, which is SSRI is used for first line treatment for any of those six things that was broken down. The six things, which is your panic attack, your OCD, generalized anxiety, antidepressants, which is number one. Okay, then anorexia nervosa and anxiety. So anytime they ask you what is the first line of treatment for any of these things that we mentioned, SSRI is number one. But one thing about SSRI is that it causes erectile dysfunction, and because it causes erectile dysfunction, they can give it with Wellbutrin, okay, which is a atypical antidepressant. Wellbutrin. Sometimes so Wellbutrin, which is this one here, Wellbutrin. Then we have another one that is, and another thing about SSRI is that it has a high suicidal effect. So, especially in the children and the adolescents. So, whenever it started on children and adolescents, they always have to make sure that they they monitor for suicide. So that is also important because you have to look at signs and symptoms of suicide, okay? Or when you start them on this medication, they have high in their mood is elevated, things like that. You may monitor patient for suicide. Then SNRI, also known as serotonin norepinephrine reuptake inhibitor. This one, it does two things. It increases the serotonin and also the norepinephrine. Unlike the SSRI only acts on the serotonin. So because this one affects this norepinephrine, that is why it can increase the blood pressure. So that is why you have to monitor blood pressure. And another thing you should remember in SNRI, I always use the N in the middle to remember neuropathic pain. It's not that it's neuropathic pain, it is serotonin, not epinephrine, but I usually use N to remember neuropathic pains because we use it for neuropathic pain. So that is, for example, Effexor, Duloxetine, Cymbalta. So let's say somebody have depression and they have all this neuropathic pain. Which one is safe or better to give them? That is SNRI. Then we have another one that is the TCAs. So the TCAs is the tricyclic antidepressant. So this tricyclic antidepressant, you need to know the ending. They usually end in lane, amitriptyline, nortriptyline, comipramine. There's other medication. Remember, I just listed examples because we can't list everything here. So this one, the TCAs and MAO, they are the older antidepressants, but they have a lot of side effects. So for TCAs, you have to monitor, especially the risk. We are still going to see other side effects of those medication, but this is just a summary. I like to put a summary, and that is why I put a summary as you can see. So we have the MAOI, monoamino oxidase inhibitor. So this one we use the mnemonics no popular meds. So that is your Nadel, Panet, Maplan. So these ones you have to monitor and have a dietary restrictions. So dietary restrictions is so important with we call it tyramine diet. Tyramine diet because it can cause hypertensive crisis. It can cause hypertensive crisis. Then we have the atypical ones. The atypical ones is your bupropion, which is Wellbutrin. And also remember that this Wellbutrin, it can also be used as another name, bupropion, which is your Wellbutrin. It also has another name called Zeband. So Zeband is the one we usually use for smoking cessation. Smoking cessation. Then we have another atypical one, which is the mirtazepine or mirtazepine. So I always remember it as mirtazepine. So this is the one that stimulates appetite. So let's say that patient is on mirtazepine, which is Remelon, and patient is complaining. Let's say patient have depression, and you know when people have depression, there's tendency that they may have loss of appetite. So this is the one that will help. Is an antidepressant, but it also stimulates their appetite. So we call it mirtazepine. Okay. So what are the things to monitor here? You can monitor their weight because when they start eating, it can lead to weight gain. So monitor their weight because it stimulates their appetite. Another thing is that it can cause sedation. Sedation. Then we have trazodone. People always take a trazodone off label or for what? For off label for sleeping pill. Anytime you ask about trazodone, they will tell you it's a sleeping pill. It's not just a sleeping pill, it's used for what? For depression. So this is your antidepressant. So if you break it down, so this your SSRI, SNRI, SDR, SDNR. Sometimes that is where you can also find your Wellbutrin. Okay, and then you have your MAOs and TCAs. Then this is another breakdown. Remember, I'm breaking down the medications for you in a simple way. Okay, antidepressant, psychiatric medication in a simple way. The next medication is your mood stabilizers. So where do we use the mood stabilizers? For bipolar disorder and sometimes schizoaffective disorder. So those medications we call it a mood stabilizers. And what are those medications that is under mood stabilizer? These are for lithium. Lithium is number one. That is the gold standard for bipolar. Okay, gold standard. And another thing to remember about lithium for the exam is that it has a narrow therapeutic index. So requires you to monitor the kidney, the thyroid, the pregnancy. So if they ask you what are the labs to monitor before you start patient on lithium or why they are on lithium, so you need to know the labs. And it also um anti-suicidal. So if somebody has a risk of suicide, this will be the best to give them. Okay. And when we say there is a narrow therapeutic index, which means the range that will just a little shift in the range can cause a side effect or adverse effect. And some of those adverse effects is like tremor, nausea, vomiting, you know. So because normally we want the range because the range is usually depending on the book or whatever you are using is usually between the zero point 0.6. Some will tell you zero point 0.6 to 1.2. Some other book will say zero point 0.8 to 1.2, but just make sure it's not more than 1.2. When it's 1.2 it's still okay, When it's 1.3, you are monitoring it. When it's 1.4, you are monitoring it. But once it is 1.5, you have to stop, you have to discontinue it. So that is to tell you, because that little change in the range can affect or can cause all those side effects. Then you have another mood stabilizer, which is the valproate or depakote. So this one is also a mood stabilizer, but this is for it's also an anti-seizure. So you have to monitor the liver. Another thing you need to monitor, I know I listed it in this PowerPoint, but I'm just summarizing everything because each of the medication, you need to look at it, you need to know what to remember. For example, like lithium, you need to monitor the kidney. And lithium can also, side effect of lithium is also raise WBC. It can cause agranulocytosis. Okay, then it can also cause Epstein anomaly. Sorry, for a pregnant woman, Epstein anomaly. We will still see it in the slide. Then the valproate acid or the depakote, that one can cause spina bifida. Then you have the carbamazepine. So this carbamazepine, I usually highlight the three A's. One A is it can cause a plastic anemia. Another A, it can cause agranulocytosis. Then another A, it is always causing a rash in the Asian population. That is why you screen them for this HLA-RA, this genetic screening, because they have a tendency of causing rash, which is that Steven Johnson syndrome in people that are Asian population. So this is carbamazepine. So always remember that. Then we have your lamotrigine. Lamotrigine is another mood stabilizer, but the difference is that when somebody is on bipolar mood, bipolar is a patient is on two pole, bi and polar. So when they are on that manic stage, we give them lithium. But when they are on the depressive stage, that is why we say depressive, bipolar depressive. So when they are on the depression stage, we give them lamotrigine. And also lamotrigine can cause Steven Johnson syndrome. But remember, in the exam, if they are not specific with the Asian population, that is lamotrigine causing Steven Johnson syndrome. But if they are specific and they said Asian population, sometimes they may not even, they will use the word Chinese population. We know Chinese is Asia, so that is carbamazepine. Okay, if they are specific in that Asian population, that is carbamazepine. But if they are not specific and they just mention the depressive stage and the one that causes the rash, then that is your lamotrigine. Then we have another class of medication, which is the antipsychotic. Breakdown. So under the antipsychotic, we use this medication for psychosis. So we have the first generation typical and the second generation atypical. And we have another generation that is partial dopamine agonist. Some people still group it under atypical. So under typical first generation, that is your haloperidol, we call it Hadol, or you can look up the other medication, HCT, which is chlorpromazine and the tiorizine. Okay, just look it up and see the spellings. But that is, I usually remember it as HCT. H is your Hadol, chlorpromazine, and tioridazine. So that is the most common one that is known there. And it causes, one thing about first generation is that it causes increased extrapyramidal symptom. We are still going to see what is extrapyramidal symptom. Okay, and it also causes neuromalignant syndrome. It causes extrapyramidal syndrome and symptoms and neuromalignant syndrome. So EPS, we know the symptoms of EPS. We will still see it, but you have to know EPS is very high yield in the exam, where you have that dystonia, which is that stiffness of the neck, akathisia, which is that restlessness, you can't sit still, akanesia, which is that and they are very sluggish, they don't feel like getting up. Then tardive dyskinesia. The tardive dyskinesia is the one that they have the smacking of the lip smacking. And finally, we have the pseudo Parkinsonism. They have a symptoms like Parkinson disease. So that is your EPS. Then we have the neuromalignant syndrome. Neuromalignant syndrome is too much of antipsychotic. So when they have too much of antipsychotic, you are going to see them have those symptoms of high temperature, creatinine kinase, elevated WBC, you know, they are going to have that muscle rigidity. It's like a sign of overdose. Then we have the atypical. The atypical is the one that I always like to sing a song. Zypresa seroquel respedal. Zypresa seroquel respedal. Zypresa seroquel respedal. It causes weight gain. So this second generation, you can remember it with O. O is olanzapine. O is olanzapine. Okay, olanzapine. Then when you remember O, you remember O for obesity. O for obesity. This atypical generation or second generation, they causes more of metabolic effects. They causes less EPS and NMMS. Okay, so they cause more of metabolic syndrome, that weight gain. If they ask you a question, what is the reason that women stop taking olanzapine or any of these atypical antipsychotic, is mostly because of weight gain. It causes weight gain, so it causes metabolic syndrome. It can increase their blood pressure, it can increase their lipid profile. So those things. And in that atypical antipsychotic, you have the olanzapine. Olanzapine is the one that mostly causes weight gain or for obesity. Then we have risperidone. Risperidone can cause galactoria. It looks like they are producing milk. Okay, especially for the male, it looks like they are producing milk. So when a patient is on risperidone and you start noticing milk discharge, we have to stop it. Okay. Then we also have the quietapine. Quietapine is more sedative. It's more sedative. So remember, that is also called seroquel. Seroquel, sleep. Quietapine, quiet. So that is the one that causes more sleep. Then we have another generation which is also included in the atypical generation, but sometimes they separate it from the atypical, and that is this Abilify. Okay, that is this Abilify. So this Abilify, I, I always remember A for awake. That is the one that it makes patient it doesn't cause sedation. So this will be more safer for elderly more than the quietapine. But if they ask you which one will cause less weight gain, the one that will cause less weight gain, we use this mnemonic ZAL, ZAL. That is a ziprasidone, Abilify, Latuda. So that is the one, this thing here, that is the one that will cause less sedation. Okay. So it lowers EPS and metabolic risks, but less sedating. So remember, I'm just trying to rush this topic, but the video that I sent was 2 hours. So this is your ZAL, the one that is less sedative. Z is ziprasidone. A is aripiprazole, which is your Abilify. L is your Latuda, which is your Lular, Rularsidone. Okay, it's also known as Latuda. So please always remember that they causes less weight gain. Okay, so this is the one that is more preferred in elderly, Abilify and Lorasidone, which is your Latuda. The one that is causing more weight gain or causing more sedation, the one causing more sedation, risperidone, and I said that risperidone also causes a milk discharge, and quietapine. Then another class of medication, remember I told you is five classes of medication in psych. Anxiolytic is number four. What are the anxiolytic? Anxiolytic is the one that we use for anxiety. Anxiety. So what are the ones that we use for anxiety? It is grouped under three. Benzodiazepine. I didn't group all of them here because we have the classification of benzodiazepine. Under the classification, you have the short acting, the long acting. So you remember, but just remember the benzo. The benzo. So benzo, somebody driving benzo, Benz. You see that Benz is very fast. It's very fast. So benzodiazepine, okay, it gives a rapid relief of anxiety. But the problem with benzodiazepine, which is where you have your Ativan, Librum, Valium, all those medication, the problem is that they have a high risk of addiction. But you we give it before. So let's say you start patient on SSRI. Remember, SSRI was our first one. So SSRI takes 6 to 8 weeks before it starts working. So if you give patient SSRI, they will tell you that this is not working. Okay. So what do? We start them on anxiolytic benzodiazepine for short period. Okay, we don't want to give it more than 2 weeks because of the risk of sedation. But if you want something without sedation, but it works slowly, that is buspirone, which is your busper. So think about Benz. Benz is very fast. When somebody is driving Benz, Mercedes Benz, they drive very fast. But when somebody is driving a bus is very slow. So Buspa or Bospa is very slow, but it do not cause addiction. So if you are looking for something that will not, the patient will not have risk for addiction, you are going to use Buspa. It works slowly, but then it's for no dependency, but slower onset. Then the last one is the hydrozine or hydrozine. So this is the one that we use for is an antihistamine, but they also use it for anxiety. So the last class of medication is your ADHD medication. So remember where I started. If you can master all these medications that I mentioned, let me tell you from the point that I remember these five medication, I stopped struggling with psych. I struggled with psych medication for years. I can't remember it, I can't understand it. But immediately I came to understand that there is just five classes of medication in psych. Everything that you are prescribing in psych will be under these five medications. So the next one is your ADHD medication, which is under ADHD medication, we have our stimulants and the non-stimulants. Under the stimulants, you have the Adderall, Ritalin, and Vanash. Okay, I'm not here to start breaking down because some of them we start giving it at the age of 6. Okay, some of them we start giving it at the age of 3, but that is not what here. What you need to remember about stimulant is that it causes appetite suppression. Number one thing, it can cause insomnia. Remember, when anybody is on stimulant, what happens with stimulant? It can cause insomnia, it can suppress the appetite. So, what do we monitor here? We can monitor their weight. You can put the child on supplement because it's going to affect their weight. Then we have the non-stimulant. Under the non-stimulant, we have the atomoxetine, and then we have the guanfacine and clonidine. So these ones are non-stimulants. So these are non-stimulants. So we break it down under stimulant. We have it like this: amphetamine and methylphenidate. So it's the same medication. I just broke the name down. Under Adderall, Adderall is your what? Amphetamide. I always remember it as A for A. Amphetamine is your Adderall, but your methylphenidate is your Retlarin. So in the exam, sometimes they use the word example of stimulant is amphetamine. Example of another stimulant is methylphenidate. Okay. Then you have your side effects of stimulants. These are all your side effects of stimulants: insomnia, reduced sleep quality, headache, elevated blood pressure, decreased appetite, weight loss because the person is not eating well. Okay. Then patient education while they are on stimulant, very important. They have to take it early in the morning. Remember, we say that stimulant causes insomnia. So the best time to take stimulant is in the morning because if you give it to them at night, they will not be able to sleep. Okay. Monitor their vital signs, especially their blood pressure, especially their growth. This is very high yield. Remember, we say that it suppresses their appetite. So when it suppresses their appetite, there's tendency that this child is not eating well. Okay. Avoid caffeine. Watch for their appetite. You can give them nutrient dense meal, like you give them supplements, protein shake. Avoid abrupt withdrawal. So everything is very important. So for the non-stimulant for the ADHD, which is the atomoxetine and the guanfacine. So for these ones, these are the things to monitor there. Their vital signs: increased heart rate, increased anxiety, suicidal ideation, nausea and vomiting. But this is very, very important. So what I ended up doing is to break down all the medications that you need to know under your psych, and I broke it down. It is under five categories. Okay. Which is your This is our mental health, which is your antidepressants, mood stabilizers, antipsychotic, anxiolytic, ADHD. So that is your five medication in psych.